David Allen. And he was first introduced to me by our inaugural speaker for this COVID series. That was, of course, Dr. Swain Chen from Singapore. And at that time, it's not just the fact that I was in Singapore for a long time, but what I like about Singapore and Qatar is they're very similar to each other in many different ways, whether it be size or systems or many things. So I think many of the things they have learned, are learning in Singapore, will be super applicable to us in Qatar as well. And you'll probably see that from the talk. But let me tell you a lot more about David, because when Swain introduced me, he said, you don't want just anybody. Dr. David is actually a very frontline person, and you're going to hear about what that means. But what I like about David is his background. He's a real product of Texas. So I spent a few years in Texas at the university. And Dr. David did his undergraduate at Rice University in Houston, and after which he graduated with honors from Southwestern Medical in Dallas, and completed his internal medicine residency as well as infectious training fellowship in New York Hospital Cornell University Center in New York City. He was then a visiting investigator at Rockefeller University and an assistant professor in the Division of Infectious Disease and Geographic Medicine at Cornell University Medical Center, after which he was recruited to Singapore to establish an infectious disease training program, and he became the first infectious disease head of department in what was then the Communicable Disease Center. He's also a fellow of the Academy of Medicine Singapore and a senior visiting fellow of the Courage Fund Singapore. He was that from 2011 to 2020. He's currently an associate vice president of the Health Information and Transformation at National University of Singapore, as NUS, as we know it, and an associate professor in the Yong Lu Lin School of Medicine at NUS, and a senior consultant in the Division of Infectious Disease in National University of Hospital in Singapore. And with that, I just want to let David talk about Singapore's early planning in response to COVID-19. And I think it's going to be a very interesting seminar for all of Qatar. Here's Dr. David.
PK, I appreciate the invitation. I'm very happy to be here. Let me see if I can share my slides with you. There we go. Great. Okay. Thank you again for having me. So today, or this afternoon, I'm going to speak to you about our experience in dealing with COVID early on, and I'll bring you up to date what's going on recently as well. But our early experiences obviously informed us dramatically. Just to remind everyone, if you don't already know, Asia is an emergency diseases hotspot. Lots of zoonoses have been discovered over the last several decades. The numbers have been going up. Both zoonotic and not zoonotic, and a variety of species have been involved. And if you can see on the hotspot on the map, Asia and South Asia and Southeast Asia have a greater incidence of this occurring. With the understanding that preparedness is a global exercise, you can see how money has been spent from development assistance in 2019, just a fraction of the $40.5 billion was spent on pandemic preparedness. So that shouldn't come to a surprise, be a surprise to anyone. It has been a big issue. There have been lots of panels convened after Nipah, after SARS, after pandemic flu. Everyone wrings their hands and we talk about it, but we don't get too much farther than that. The main source of pandemic preparedness, as far as funds, have been through the WHO. Others, agencies, foundations, and organizations certainly contribute, but the vast majority of the money is funneled through WHO to apply. The preparedness, not only has it been wanting, but it's also been sporadic. And so you can see countries that have revised their plans, which is a surrogate for telling you for influenza preparedness. It's a surrogate for telling you about pandemic preparedness since 2010. It doesn't mean that a plan means they have funded it. It just means they have a plan. But you can see a lot of countries either have no plan in place or their plan is more than 10 years old. And what does preparedness mean? So based on these metrics of global pandemic preparedness, you can see some of the countries at the top have actually done the poorest. Some of the things that they measured were funding for prevention and detection and reporting and rapid response and compliance, et cetera, et cetera, et cetera. despite all of their preparedness, things didn't turn out the way they wished. And here also is another way of showing the same. Those countries that are best prepared, at least by the metrics that were used, and at that time, you can see how they ranked as far as number of cases per million population. So the U.S., supposedly best prepared, has the 11th most cases per million in the world. And some of the countries, maybe Somalia, that was least prepared, much fewer cases per million. Now, you could argue whether there's reporting. You can argue a lot of things, but I think in general, I think the take-home message is our metrics for measuring preparedness really didn't play out. So let's get to Singapore. That's why I've been invited to speak. Singapore's connected to the world. There's lots of airlines come through. This is all pre-COVID numbers. Lots of airlines come through, lots of cities, lots of countries, which either come in or out of Singapore. And each week, 7,400 flights and 65 million people through per year would come through here. So you can see that we are connected to the world, and whatever happens in the most faraway place, we're going to hear about or be exposed to within a few hours of their flight landing. So our preparedness pre-COVID was influenced by SARS in 2003. The lessons learned: we had 238 cases, 97 were in healthcare workers, and we had 33 deaths. So it reminded us that we're the nexus, that disease knows no borders. And as a response, efforts were made to maintain and bolster working relationships across a variety of entities, whether it's basic scientists, public health, government, etc. And the strategies involve the whole of government being involved, expanding capacities. You can see a picture of one of our newer, a photo of one of our newer buildings, which is the National Center for Infectious Disease that opened up last year, predominantly driven, many years in the planning, driven by the events of SARS in 2003. Regular exercises to make sure that we were prepared, lots of supply management, meaning stockpiling, etc., was involved. So this was the strategy, and it's been tried and tested on a regular basis ever since. So this is the strategy sort of in a diagram. There's comprehensive surveillance, and we'll go through some of these: aggressive containment to the leadership and effective efforts to prevent, and steps in all of those places. So our infrastructure has been refined over the years as far as the crisis management, again, influenced by past experience. We knew we needed to expand capacity, so we tried to have flexible capacity. Buildings that could expand, they may have 300 beds, but could be expanded for 600 or 900 beds. We realized early on in the outbreak that many patients were stable. We insist on isolating everyone, not at home, but they need to be isolated in a facility. So we made community isolation facilities available. We upgraded, I mentioned National Center for Infectious Disease, but other hospitals were built with pandemic capacity in place. A lot more isolation beds than we otherwise would have, and a lot of rooms that could be converted to isolation rooms where they needed. Plus, we expanded our basic research capacity, which I'm sure Swain spoke with you about. The whole government approach was, it's basically a task force made up of a variety of ministries: manpower, education, transportation, communications, environment, etc. It's basically to direct the response and coordinate with the community engagement, and also to interface with the international community to make sure we're all speaking the same language. There's part of the leadership, in addition to the whole of government, was having public communications. And still, even though the number of cases have gone down dramatically, I get this, all of us get updates twice daily through WhatsApp regarding what's going on, the number of cases in hospital, in ICU, in isolation outside the hospital, the number of people have been discharged from hospital. Twice a day we get updates. It goes to everyone. So there's a lot of transparency, swift response to any changes in the kinetics of the number of cases showing up, and quick intervention to deal with falsehoods or people spreading conspiracy theories. Obviously, we have social distancing, and early on, the usual things were suspended, the senior groups and other high-risk individuals, and eventually all groups were activities were suspended, co-curricular activities for kids, entertainment venues. Everybody began telecommunicating at home. It was actually quite nice in the hospital, where I obviously was coming every day, because the office space was very quiet. I was able to get an enormous amount of work done, so it was quite nice. And limited gatherings, whether in outside work, whether in interpersonal spacing or in public spacing, it was restricted how many people could be together, as it is throughout the world when lockdown took place. Public health measures, the usual things took place, and minimizing non-essential activities, the usual metrics. There was a big effort to support healthcare workers. They were overworked, and so a lot of work was gone in by the government, by hospital administrations, by a variety of outside agencies that never had much to do with healthcare, to really support, whether it was providing vouchers, free meals, pick up laundry, money, gifts, all sorts of things were done to try to let the healthcare workers know that they were appreciated and supported. Counseling services, psychological health apps were made available free, and everybody was encouraged to recognize the signs of burnout. So who did we test in those days? Well, we used our case definitions, and the case definitions changed quickly. Currently, and these are the most liberal of guidelines, we test all those who have acute respiratory illness to any degree, who've had some epidemiologic risk factors, or who've had a febrile acute respiratory illness in the last several days. We test all people with community-acquired pneumonias, regardless of what's going on. Obviously, if someone has an aspiration pneumonia or a nosocomial pneumonia, we don't consider SARS-CoV-2. But in a community-acquired pneumonia, we learned early on that you could not predict with any certainty. So we began to test all community-acquired pneumonias. Anybody who travels to Singapore gets a swab on arrival, and then depending on where you came from, you get a stay-home notice for 7 to 14 days, and you must stay home. For foreign workers who continue to stay in Singapore, and we are dependent on our foreign workers, they get tested every 1 to 2 weeks, but they are returning to work, and we'll get into that a little bit more later. Surveillance strategies, basically it's been liberalized, but we used, again, the case definition. We traced contact of all lab-confirmed cases, and we did enhanced surveillance early on. Basically, we picked a day, and I'll show you a graphic in a bit, and then we swabbed every person in the hospital that had a respiratory tract infection across Singapore. Private hospitals, government hospitals, what have you. Anybody that had a respiratory tract infection, particularly pneumonia, got swabbed just to make sure we knew where all the cases were. Try to make this as palatable as possible. It was free, and if you had COVID, your cost of care was free, especially in a hospital. And we tried eventually. It wasn't our first step, but we opened up public polyclinics and general practitioners so that they could do testing. Initially, we tried to keep the tests in the tertiary care hospitals and main hospitals. That became untenable as the numbers grew. And we realized that we needed to expand that. So you'll see in a moment that expanded quite generously. Here you go. Here are the public health preparedness clinics. There's over 1,000 across the country. And you can either go online or you could go to an app, and you could quickly find a clinic near you that would allow you to get consultation and treatment. So we tried to make it as accessible and as affordable as possible. So we've ramped up early on. Obviously, with everyone else, we had concerns about shortages of swabs, which we addressed by not trying to buy swabs elsewhere, but we designed, built, and validated nasopharyngeal swabs ourselves. We're able to make quite a number of them a day. We're able to make several million a month. And so we've gotten up to where we can swab up to 40,000 a day now with the capacity with pooling to go well over 100,000 swabs a day. You can see the number of total swabs per thousand population we've performed and the number of unique patients that we've swabbed. And we're swabbing, we think, appropriately. We have less than 1% of our swabs have been positive, telling us that we're being aggressive in our surveillance. There's also other ways to survey people. There's an app you can download to your phone that will use timestamps and Bluetooth signal strength and tell those at the Ministry of Health, if you turn positive, they'll be able to see everybody you were in contact with and be able to contact trace them quickly. This is cut down enormously. Early on in the pandemic, before we had these, we used other data, CCTV, people's recollections, phone calls, et cetera, to try to find out where they've been and when they've been. Very laborious. This has helped dramatically. Now we have what's called safe entry. So whenever you go anywhere, you use the QR scan, a code you scan, and it automatically tracks that when you're there. And then when you leave, you sign out. They know everybody who's there at one time. If someone turns positive, and if you were there long enough, then they'll quarantine you. But you have to do it everywhere, even the hospital. So contact tracing, obviously, activated once a case is confirmed. They track back everybody they've been exposed to. The teams have expanded, and we've used people that have maybe furloughed. For instance, the Singapore Airlines, some of the pilots got involved in contact tracing. Military was involved in tracing, the police. And we've had greater than 100 teams, which means more than 1,000 people working on this. And they've used a variety of technology to try to aid in that. So to ensure compliance, we quarantine people up to 4,000 a day, and there have been more earlier in the pandemic. Right now, there's about 18,000 people under quarantine, and if you violate quarantine, it's taken seriously. The government will fine you, and you're jailed, or can be jailed. They'll also remote monitor you through GPS. If they find out you're out of your house, they'll track you down and throw you in the Hoosgow. They'll also do spot checks. Border controls, we obviously tightened our border controls. Right now, we're trying to liberalize them with countries that have low incidence of COVID in their communities, so China, Taiwan, New Zealand, etc. And it's not always reciprocal, but we're trying to open up the country a bit. Again, for those Singaporeans who return from overseas, if they've been in a low endemic area, they'll be quarantined or stay home, for 7 days. Those who've been in a high endemicity area will stay home 14 and be tested throughout. And Singaporeans are advised not to travel except to these places where the travel restrictions have loosened a bit. So again, the isolation, we keep all our positives in hospital and in isolation facilities, but not at home. And we have criteria of when they can be released from isolation, and there's strict quarantine of their contacts, and there's stay-home notices, again, for people who have not had contact but are traveling from places where they may have had contact. There's help, care packages and resources and financial support to make this a bit more tolerable. It's still painful, but there's some effort to ameliorate that. And again, these are some enforcement examples that they will deport you if you're not a permanent resident. They'll take your passport if you are a Singaporean. Doesn't make not much of a disincentive now since we can't travel much, but they will fine you and they'll put you in jail. They're serious about this. There's also some other measures. Government economic interventions I've mentioned briefly. There's some education, and obviously our publications, which I'll speak to in just a moment. So the government, a variety of measures you can see in the right of this slide. There's been a number of stimulus packages that the government has rolled out. Many hundreds of billions of dollars have been spent and to support the country, and it has made a difference. Economy is still slow, but you can see, depending on what industry you're in, what sector, you get different support. So aviation and tourism has been roundly injured, so there's higher support. Other sectors less so. We've educated the community, the usual sort of ways to do so, whether it's on TV, commercials, print ads, bus stop posters, etc., to help remind people. We've tried a variety of techniques, such as cartoons, just to try to reach everybody. And these COVID-19 chronicles come out of the School of Medicine, and they come out weekly and have been actually quite popular. I've been involved in some activities, one of which is COVID-19 updates from Singapore. It went on weekly for 24 months. We had speakers from around the world speaking on topics from macroeconomics to psychiatry to public health to basic science to treatment, etc. And very well received. On our last one, it's the far right. We had the Director General of the World Health Organization and 16 other colleagues on. It's quite a well-received event. Lots of research coming out. We've been involved in the remdesivir trials that were published in New England Journal, and some development of neutralization assays, dealing with public health recommendations, epidemiology, and psychological impact. There's been hundreds of articles, guidelines, etc., coming from Singapore. We're quite proud of being focused and working hard trying to contribute to the international dialogue. So we've been able to do all these things, but what impact did it really have? Well, first you need to know a little bit about our alert levels. Green is all is good, yellow is beware, orange is trouble ahead, and red is trouble. So DORSCON means disease outbreak response system condition. Singapore loves acronyms. And you can see there's an increasing incremental impact on either daily life or advice to public or nature of the disease. So we use these alerts. We've never officially gone past DORSCON orange, despite the fact that we often meet many of the DORSCON red criteria. But this has been our early response, and this starts in January and goes until late April. You can see here, or May, excuse me, the 1st of May. And I won't go through this in great detail, but you can see there were imported cases to the far left, very few at this point, but those got our attention. The first case was on the 23rd of January, and we went to DORSCON orange 2 days before because we were anticipating this. And then we had local transmission in the community. You can see the orange to follow the imported cases, again, fairly small. And then we had the imported cases, our return of many of the Singaporeans living and working abroad. The government said, come home. And they brought COVID back to Singapore. And then it spread from them into the community and then to our foreign workers, which is the green line, and the dormitory residents, also the red line. You can see on the 7th of April, we had what we call circuit breaker, effectively locked down, but it's the term that was preferred by the Ministry of Health. That was imposed, and it lasts until the 1st of June. So this is the early part of our outbreak. So I'm going to show you up until September, but you'll get a sense of this epidemic curve. So let's chat about the foreign workers just a bit. Singapore's population is 5,600,000, of which 1,300,000 are foreign workforce, of which some are professionals, about 370,000, and about 975 are unskilled workers, and about 300,000 are construction workers. So there's a variety of ways that foreign workers are housed. I'm a foreign worker technically, and I live in I live in housing provided by the university and have. But many of our, obviously, our domestic helpers work in the employer's home. Some of our foreign workers are actually Malaysian and travel back and forth across our causeway. We also have folks in dormitories and public and private homes. So this is the distribution. It's important to lay this out because our largest group of folks that became infected were our foreign workers living in dormitories. We've got 43 purpose-built dormitories, which take care of 200,000 men, of which the largest of the dormitories house 25,000 men. We've also got some factory-converted dormitories, of which house 100,000 men. So of a total of 323,000 migrant workers living in dormitories, not living in Malaysia, not living in employers' houses, not living in other housing, 300,000 of them were in these facilities. And as you might imagine, housing can be crowded. Double bunks, bunk beds, and anywhere from 8 to 12 and even higher beds per room in these large facilities, usually located near where the industrial areas are. And the industrial areas are here in gray or bluish gray, and you can see the dormitories are located nearby. So the challenges in working with COVID-19 and our migrant workers were to identify them, large volumes of men living in close quarters, to be able to isolate them, to find housing for this many men, to trace them, to quarantine them, and to do so at lightning speed because we learned that it's transmitted asymptomatically. So just the volume of testing was a logistics problem. We had to ramp up our testing facilities. Swain was involved in that and still is involved in that, as well as swabs and reagents and tubes, et cetera. We had to try to identify and prepare appropriate new repurposed facilities and move them in there. We thought that had not been infected and trying to protect them, feeding and monitoring them, and getting the manpower mobilized to be able to provide these services was quite an effort. There was a need for economic support, emotional and psychiatric support. You can imagine these men were frightened, being moved around and seeing that their friends had fallen ill. It was quite a challenge. And eventually, as things have drastically improved, how do we safely continue to allow these guys to work that are essential workers, and those who aren't essential workers, once they've recovered, to allow them to return to work? So lots of logistics that we had to work our way through. So this is the isolated epidemic curve for our migrant workers. You can see when the circuit breaker was in place from April to 1st of June. And you can see how it is slowly declined. There was a little blip in the August, but that again has gone down. And you can see most of these men previously were detected through surveillance. Now more of them we've been able to get our hands around the situation, and more are being detected or isolated before detection. And as far as proven infected by nasopharyngeal swab, 54,300 have been proven, which is 16.8%. But we know that more have been infected than that. These are some of our community isolation facilities, look like community isolation facilities that have sprung up around the world, but we used a large exhibition center. We've used old schools. We've used old malls. We've used all sorts of facilities to try to do this. And we're changing the living circumstances in the dormitory. Our current dormitory had a certain amount of square footage per man. That's going to be increased. Number of beds per room, you can see 12 to 16. They have to be less. They're not going to be bunk beds because somebody on a top shelf, obviously they're going to, when they cough or sneeze, it's going to fly farther than a meter when they're got a launch platform above the floor. So no more bunk beds. We've also built some additional facilities that are quick built. They're not intended to last, but they're intended to last until newer dorms can be constructed, and these are also spread out. We've also keep an eye on the gentleman to be able to determine who has been cleared by subsequent quarantine, clearance from quarantine, and surveillance. They go back to work, so they have apps on their phone, how to keep people that are on stay-home notice at home, and how to give apps so that the workers in their own language can seek medical care, or at least alert medical folks that they need attention. So again, looking at our different breakup of our epidemic curves, the top one is the imported cases. Again, very low over here when we were getting cases from China. And then these are the returning Singaporeans. These are students coming back from the UK, from Europe, the United States. We did not initially isolate the asymptomatic ones. We didn't quarantine, the asymptomatic ones, because we did not know then. But it led to outbreak in the community. And then at some point in time, our foreign workers, it was introduced into that population and then caused cases there. So we've had 5 waves, essentially: the imported cases from China, the early clusters as a result of exposure to folks from China, returning Singaporeans and permanent residents from overseas, and then getting into our migrant worker population, and finally where we are now from May until the present, where it's in the community and small clusters that break out. So you can see here, first wave, second wave, third wave, fourth wave, fifth wave, which is what we're in now. So currently, this is where we are. We have no one in the ICU and haven't had anyone in the ICU for probably 6 or 7 weeks now. The general wards were down, in the hospitals were down to 29 as of the 25th. This is isolation facilities. We've got 268, and we've had 27 deaths. This is actually, 57,000. I think we're actually up to 58,000 or close to it. So how do we measure how well we respond? And obviously, pandemic preparedness, at least the way we understood it before, was not very good. Those metrics were not very good. So this has been put forth by folks in public health as a way to assess how well you've done, to assess your performance as a country. Ability to detect and break transmission change, to decrease deaths, to minimize hospitalizations, to support individuals financially, make sure that food and medicine's available, and maintenance of usual health services. These are just proposed steps and things that you could measure that seem to make sense. So, what's an assessment as of late September of how we've done in Singapore? On the bright side, we didn't default to allow viral spread to achieve herd immunity. So we feel that we were very proud of how things went initially. We were a little concerned, not a little, we were concerned about how things went in the dormitories, but we feel like we really made a concerted effort to address that and try to rectify that for future pandemics that will come. We're talking about Pandemic X now. We did well screening and early identification of patients and stratify and triage patients and get them to another facility before the hospitals became overwhelmed. We managed to prevent fatalities by early recognition, early triage of patients. So our case fatality rate is less than 0.05%. We've expanded our capacities even beyond what we had. We thought we had sufficient. You can never have too much, it turns out. That's our isolation facilities. We've expanded our contact tracing and our understanding how to use technology to monitor people. The testing capacity, we've become self-reliant. And we've become self-reliant with a PPE and diagnostics, et cetera, by getting scientists, the manufacturing industry, and the government involved. What could we have done better? Well, if we had appreciated asymptomatic spread, which we were not alone, but if we had appreciated it earlier, we could have quarantined all the Singaporeans who returned home from March. We would still have had cases in the community, but it wouldn't have been the surge. We could have tested all before they were released from quarantine, those we did quarantine, even if asymptomatic, and instead of assuming that no symptoms meant no infection. We could have recommended wearing face masks sooner. We waited until WHO recognized asymptomatic transmission to do so. We were not alone. We could have understand the implications of communal living. The Prime Minister has said would have acted more quickly and aggressively to control it if we would have appreciated that. And we could have moved from the tertiary hospitals and general hospitals. We could have moved testing out into the community a little quicker. We did it pretty quick, but we could have done it a couple weeks earlier. It would have decanted some of our tertiary care hospitals where people flooded, because that was the place they could have gotten tests. The government wanted to control and have an idea of what was going on, and they felt they had better control by having it come to tertiary centers. It makes sense, but volume became a bit much, and so could have decanted to those places earlier to get testing. So things that are of current and future interest is we have low community seroprevalence, very low community seroprevalence. It may be 16.8% in the foreign workers, but it is clearly less than 1% in the community, meaning we have a vulnerable population. We're actively trying to develop acceptable alternatives to PCR, not just the inconvenience of a nasopharyngeal swab and the pain and the discomfort and the risk of a nasopharyngeal swab, but PCR takes a long time. And it's laboratory intensive. We're looking for alternatives, and we're working here at National University Hospital. We have a number in development that look quite promising, but we'll see. We need to open our borders because that equals economic recovery and important for our economic recovery. We need to open our restaurants, places of worship and entertainment for mental health, the cultural health, the financial health of these places that we hope will be there when we can go there. We're trying to understand the role of monoclonal antibodies and the impact of vaccines. I've been very involved in both of those, and it's a fascinating area. And more is known than previously, but there's still some uncertainties. And we need to efficiently utilize Singapore's greatest natural resource. We have no oil, we have no gas, we have nothing but our people, and we need to utilize them more. So the take-home messages are serious, focused, honest, well-funded preparation helps. Doesn't prevent, but it does mitigate. We need flexibility in how we build our facilities, whether it's a parking garage, whether it's a hospital. We need people cross-trained and prepared to be flexible, they may be critical care ICU nurses one day, and they may need to run a ward the next day. Or they may be O&G nurses, but they need to be able to move. And the same way with physicians. It helps to have fact-based, regular, honest messaging. That has helped enormously. We can see countries where the government is saying one thing, the public health agencies are saying something else. Lots of chaos, lots of confusion. It would be hard for someone to be confused in Singapore. The messages are so consistent, so fact-based, so honest. It would be very difficult to do that. We know that aggressive shoe leather epidemiology helps with containment. Again, does not prevent, but it certainly helps prevent our healthcare facilities from becoming overwhelmed. And we need to be able to respond as new information becomes available. So with that, I thank you for your attention, and I'm happy to take any questions that may come. I'll unshare at this point. Oops.
So, hi, folks. For the people that are listening, I did send this message out through some chat channels, but if you have any questions for David, please use the Q&A and address all participants. Do not address specific participants, and try not to use chat, because this way your questions will get heard. If nobody else has questions to begin with, let me start with the first question. Are you there, David?
Yes, I am.
Okay, just making sure. So my first question was, of course, the migrants, because, I mean, there's a ton of similarity between Qatar and Singapore. One of them is definitely the migrant worker community. My question was, you said it was 16 plus was probably the infected, and you said it could be a lot more. Do you think that the migrant community, especially the workers in the dorms, is close to a herd immunity? And how many more new infections are you seeing, if at all, in the migrant workers in the dormitories?
So I will tell you honestly, I do not know that information. I believe that is closely held information. and I do not know that. I am. We still see sporadic clusters in the dormitories. One could interpret that we're not seeing more through a variety of interpretations. I will tell you that the men have been dispersed, so additional transmission is much more challenging now. So I can't say that we've reached a herd immunity in that population or not.
Okay. So I have a ton of questions, but some other questions are coming in, so I'll give everybody a chance. I want to be fair. And so somebody has asked a pretty good question regarding the case definition. What are the response strategies for cases having a CT value above 30? And does that affect the quarantine measures?
So we have a variety of measures. Initially, early on, you had to have 2 negative swabs 24 hours apart to be released based on the best available data. Now it's basically 21 days after a positive swab, you can be released. So we did have previously people in hospital 40, 60 days until their swabs were negative, no more. We also use it with a combination of serology. So we use symptom serology and PCR. We're very cognizant of CT value, and certainly individually you can take that into consideration, but from a government case definition or, excuse me, a de-isolation perspective, that precise number is not taken in, not factored in. Part of that is because we do not have one centralized place where we're doing our PCRs. We have numerous labs. They're not all using the identical platform. And so while we all agree that a CT value of greater than 30 or 31, or some would say 24, would identify those who are no longer communicable, that difference has made people a little leery of just putting up a number and saying that'll be sufficient.
I have additional question. It's a personal question, but honestly, a lot of people are apprehensive about this deep brain tingle swab. So you mentioned you've developed your own nasopharyngeal swabs. What is the reason I'm asking is I hear all this, like Australia has developed swabs that don't go as far or just do several swabs around the nostrils. A lot of people are very apprehensive of something that's going, quite deep. And I haven't had it done yet, but the people that have been subjected to it says it's pretty stiff. What's your opinion? Does it need to be that deep, or you think we can have some other types of swabs?
Well, that's a lot of questions in one. So let me try to break them up. So the answer is depending on what day of illness you were in or what day of infection, you may have higher quantity of a virus in different locations, whether it's the anterior nares, the nasopharynx, the trachea, etc. But the gold standard is the nasopharyngeal swab, and it's the posterior pharynx. So you've got to get back there. And so it's 7 centimeters, regardless of your ethnicity, regardless of your race. It's only different from age, but in all adult human beings, it's 7 centimeters from the opening to the back. So we could not violate any patents. So we had to find and create and produce our own swab. So we took into consideration the need for flexibility to get there. We took into consideration the need for absorption and retention of the material. So we tested 40 prototypes. Many of them went in my nose, sadly to say, because before we're going to validate them in human beings, before we're going to validate them in patients, we had to make sure that they were safe. So the long and short of it is, we did we went through our IRB. We got approval, and we validated our swabs. So since then, we know that you can get comparable yield if you combine a mid-turbinate swab, which is just 2 centimeters in, plus a oropharyngeal swab. That combination of swab for PCR equals the nasopharyngeal swab essentially. And people find them less annoying and less scary. But still, they're PCR. So we're looking at antigen detection, both from swabs, but we're trying to get away from swabs because if you're a foreign worker and you're getting swabbed every week or every 2 weeks to keep your job, it doesn't take long before you get tired of that. So we're looking to detect antigen, the spike protein in saliva. There's some amplification tricks we're trying. We're also looking to detect RNA through a non-PCR technique, and it's something called the Envision platform. And we have some other assays that are out there trying to use saliva as a means of doing it. The sensitivity thus far not as good, but we're still in process. One of our problems is the number of cases we have, the number of positive patients is going down, so our ability to test is going down. But we're trying to design, and we did with our nasopharyngeal swab tests that are statistically valid, that showed that they correlated very well with the commercial swab.
And one person added to that as a question. I think I know the answer, but I'll get an expert's opinion. And the swabs don't really pose, despite their pain or whatever, there's no real danger to a person from the swab.
No, they're designed to basically hit the net. You basically go till you hit the you hit the nasopharynx, and then you begin your twirling to scoop up respiratory epithelial cells and the mucus that's there, which is where obviously the RNA is. But no, the two biggest concerns with the nasopharyngeal swab, one is bleeding, which occurs with all of them infrequently. People who are on anticoagulation or hypercoagulated or over anticoagulated, you need to be cautious about. But they're not terribly risky, to be honest with you, and they're not terribly traumatic in people who are on warfarin and in range with INRs in the 1 to 2.5 range. So you have to worry about bleeding, which occurs very infrequently. And you have to worry about the swab breaking off in the nose. So ours were engineered specifically with that in mind, and we've not had problems with that. But if you have an inexperienced swabber who doesn't know where they're going or what they're doing, I mean, you can injure someone with a teaspoon of water if you don't know what you're doing. So any swab is potentially dangerous. But in the hands of someone who's has a modicum of experience, they're maybe unpleasant, but they're safe.
Okay. I mean, I don't know how much time, because I don't want to, keep people, but I just had some other biting questions, which was, I noticed you guys are only using hospitals in Singapore to keep infected patients, because in Qatar, they're also rolling in certain hotels that have been deemed as, people for, patients, okay, that don't need ICU. So I guess you didn't really have that many patients. And my other question related to that was, I assume you're only using the public hospital system and not the private hospitals, because here the private hospitals definitely aren't being used to house patients.
So we let me be clear. We are using. That's one of the ways we kept our government hospitals from being overwhelmed. Is we used community isolation facilities. So we use large concert halls and have turned them into where we can put 2,000 or 3,000 beds in there. Those are for isolation. We quarantine people in hospitals, in hotels, and we quarantine some at home. But generally, not generally, we have a fraction of our patients that are infected in a hospital or ever went to a hospital. But the vast majority went to community isolation facilities. We did use private hospitals. They agreed. To be honest with you, they were happy for the business, because a significant amount of business in the private hospital sector in Singapore comes from China, from India, from a lot of people traveling from Indonesia to come here. They couldn't come here. The hospitals were empty. So the government said, we'll pay you a fixed rate and you monitor these people. And they were quite pleased to do so.
I have one more question just come in from another respondent. I think it's a very good question. He's asking, are there any methods of prevention or dealing with this outbreak that could apply to other nations that aren't economically stable, as let's say Singapore or Qatar? I'm assuming he perhaps means like developing or emerging markets, which it's a little bit harder to contain.
I think when you look on the World Health Organization site, you'll find that a lot of countries that are considered lower income countries, middle income countries, are doing extremely well. And it's not because of all the the technology that we have. They don't have that. It's because they've engaged the community. They've got a buy-in, whether it's the village leader, whether it's the religious leader, whether it's the governor, whether it's whomever. They've managed to get people to say, this is important. We're going to protect each other. So that's why. Now, it can be very judgmental. It could be post-colonial arrogance to say it's because they're not counting all the patients and they've not tested enough. But many of them have. I mean, Vietnam is a wonderful example. They've done extremely well. Many countries in Africa have done extremely well. So I think this is a matter of getting the message out. And again, many of these countries have experienced either Ebola or SARS in the past. They understand this isn't a game. Yeah.
Okay, I think I'll ask the final question then, because it's, again, and you were pointing this at the very end, and it's a really important thing. I mean, we're just worrying about COVID-19 right now, and it is dangerous. But I can think of a million other viruses that could be a lot more dangerous. And you said we should be ready for other pandemics. I don't want you to be a forecaster, because nobody can forecast a virus. And being an infectious disease expert, what are some other virus strains that you see as potentially being much more debilitating than COVID? Because I think things could get a lot worse.
Influenza, another coronavirus.
Okay.
Yeah, I mean, those are the one. I mean, a hemorrhagic virus. The trick is all good, successful viruses lay in wait. SARS was not a great, it wasn't skillful at being a virus because it killed people, made them sick and killed them too quick.
Yes.
HIV has been our longest pandemic. HIV is a successful virus. It can lay dormant in you for a decade or more. So the tricky virus is the stealth virus. So this one was good because we didn't recognize asymptomatic spread. We didn't recognize that all these people are going around. So it's going to be a virus that learns from HIV and learns from SARS-CoV-2.
Yes, that's what I mean. I think to me, having the preparedness, as you said, is really the most important take-home lesson. I mean, because this is going to happen again.
Yeah, it's just a matter of pulling up our pants and just saying, this is going to happen. Let's just factor it into our day-to-day lives, and then we can get on with our lives. We're prepared. But to whistle and hope, oh, we're too smart. We're not.
Agree. Thank you, David, for a million other questions, but I'll send them through Swain privately because I don't want to take up everybody else's time. But it was a really fascinating, and I think there were a lot of take-home lessons for Qatar specifically. So thank you, Ray.
Yeah, thank you for having me.
Okay. And for the people that are attending, don't just go off. I think there's going to be a survey that's going to come out. So make sure you fill out the survey. Right, Omar? Hello? Oh, hello. Is David still there?
I am.
David, I will ask. I said it was finished, but can I just ask one last question because an important question just came up?
Yeah.
So one last question is, what do you think of the immunity certificate?
Yeah, I think WHO has never endorsed them. I think they're problematic. We're not being disingenuous, but it's a big issue is how long antibodies last. And are the antibodies that are measured by the Roche test and by the Abbott test, which are the common antibody tests out there, are they indicative of neutralization? Now, there's some data to say they are, but I think the big concern is can you reliably be sure that antibody that you measure today will be there in a month and a half or 2 months? And is it the right antibody? So it sounds like a dumb statement, but it's actually a very factual statement. It's very important. But there's other issues about how do you do this in an ethical way? If I'm a country that the vast majority of my income in my country comes from my workers working overseas, I might be incentivized to give them immunity passports. Yeah.
Okay, Dave, thanks once again. I think this is really it. So thanks, guys.
Yep. Bye-bye.